So, as you all know, osteoporosis is the most common bone disease in humans. It is characterized by low bone mass, microarchitectural deterioration of bone, increase in bone fragility, and susceptibility to fracture. What is the medical impact of osteoporosis? Osteoporosis generally does not become clinically apparent until a fracture occurs. Vertebrae, proximal femur, and distal forearm are the most common site of fractures. Patients suffer from pain, limited range of motion, disability, deformity, and this leads to psychosocial symptoms like depression and loss of self-esteem. Fractures associated with increased risk of mortality and future fractures. It has financial impact also. It is a serious public problem worldwide. 1 in 3 women and 1 in 5 men over age 50 experience an osteoporotic fracture. A bone breaks due to osteoporosis every 3 seconds, second only to cardiovascular disease as a global healthcare problem. In India, 1 in 8 males and 1 in 3 females over age 50 suffer from osteoporosis. Lower age of peak incidence by at least 10 to 20 years compared to Western countries. As the life expectancy is increasing, the osteoporosis is more and more visible, and the bar chart shows in green the people above 50 years of age, and the orange one is people above 70 years of age, and it shows the incidence of osteoporosis. This is the pathophysiology. Bone remodeling necessary for maintaining bone strength, aging, estrogen deficiency or other metabolic derangements causes osteoporosis. Osteoclastic activities increases and osteoblastic activity decreases, and bone resorption is much more than bone formation that leads to osteoporosis. The causes of osteoporosis are various. The lifestyle factors, alcohol abuse, smoking, vitamin D deficiency, inadequate physical activity, low calcium intake, high salt intake, excessive thinness, excessive vitamin A, and immobilization. Some genetic diseases like hemochromatosis, homocystinuria, osteogenesis imperfecta, Marfan syndrome, other hypogonadal states like androgen insensitivity, premature menopause, Turner syndrome, Cushing's disease, thyrotoxicosis, diabetes, celiac disease, gastric bypass, hemophilia, thalassemia, RA, ankylosing spondylitis, stroke, Parkinson's disease, COPD, anticoagulants, PPIs, all these ultimately can cause osteoporosis. The diagnosis of osteoporosis is from the history, the clinical risk factors for osteoporosis, related fractures, physical examination, BMD assessment, vertebral imaging, and biochemical markers of bone turnover. Physical examination gives us hint about osteoporosis. By examining the patient, as you see on the right side, if you can put 4 fingers in the loin area, it is good. Otherwise, if you can put only 2 fingers, that is rib pelvis distance, that gives the idea of osteoporosis. About bone mineral density, WHO defines osteoporosis in terms of BMD. We have T-score and Z-score in it, and the T-scores shows normal bone density up to -1. Between -1 to -2.5, it is low bone mass. We call it osteopenia, and when the figure goes down from minus 2.5 to further low is the red zone, and that is the frank osteoporosis. When a person should go for BMD testing? Regardless of clinical risk factors, women aged 65 or more should go for BMD. Men aged 70 or more should go for BMD. With clinical risk factors for fracture, young post-menopausal women in menopausal transition, and men aged 50 to 69 with clinical risk factors for fracture. Adults who have fracture at or after age 50. Adults with conditions like rheumatoid arthritis or taking medications like glucocorticoids should go for BMD testing. So these are the areas where we go for BMD testing: the neck of femur and the L1, 2, 3, 4 vertebrae. We have two scores in BMD testing: T score and Z score. T score is the score that the value compared with that of control subjects who are at their peak BMD, whereas Z score is age and sex matched. This value is compared with that of persons matched for age and sex, and it is measured by DEXA. Vertebral imaging also gives diagnosis of osteoporosis, the sign of impaired bone quality and strength, strong predictor of new vertebral and other fractures. It is performed using lateral thoracic and lumbar spine X-ray, lateral vertebral fracture assessment, and using DEXA machine. Presence of a single vertebral fracture increases risk of subsequent fractures 5-fold, risk of hip and other fractures 2 to 3-fold. Again, few words about vertebral imaging. Indications for vertebral imaging: when you should go for vertebral imaging, when women 70 and above and men 80 and above, with T score at spine, total hip or femoral neck at -1. All women aged 65-69 and all men aged 70-79 with T scores at spine, total hip or femoral neck at -1.5. Postmenopausal women and men aged 50 and older with specific risk factors like low trauma fractures during adulthood, historical height loss of 1.5 inches or more, prospective height loss of 0.8 inches or more, and recent or ongoing long-term glucocorticoid treatment. Some biochemical markers are there of bone turnover that helps in the diagnosis of osteoporosis. Bone remodeling occurs throughout life. Biochemical markers of bone remodeling include resorption markers like serum C talopeptide and urinary N talopeptide. Formation markers like serum bone specific alkaline phosphatase and osteocalcin. Evaluating biochemical markers of bone turnover predict risk of fracture, rapidity of bone loss, extent of fracture risk reduction after treatment, and magnitude of BMD increases with treatment. FRAX. This is WHO Fracture Risk Assessment Tool. FRAX tool developed by WHO to evaluate fracture risk of patients. FRAX algorithms give 10-year probability of fracture. Risk factors include in WHO Fracture Risk Assessment Model: current age, gender, prior osteoporotic fracture, femoral neck, bone mass density, low BMI, oral glucocorticoids for more than 3 months, RA, current smoking, alcohol intake, 3 or more drinks per day, parenteral history of hip fracture, and secondary causes of osteoporosis like type 1 diabetes mellitus, osteogenesis imperfecta in adults, untreated long-standing hyperthyroidism, hypogonadism, premature menopause, etc. This is a calculation tool. Using BMD and some questionnaire, one can calculate the probability of fracture with BMD. Some additional bone densitometry technologies besides BMD, these are CT-based absorptiometry, trabecular bone score, peripheral dual energy X-ray absorptiometry, and quantitative ultrasound densitometry. a few words about management of osteoporosis, some general recommendations and some pharmacological therapy. About general recommendations, adequate daily intake of calcium and vitamin D is must. National Osteoporosis Foundation recommend 1000 milligram per day of calcium to men aged 50 to 70, and for women 1200 milligram per day of calcium to women aged 51 or more and men aged 71 or more. Controlled clinical trials show reduced fracture risk with combination of supplemental calcium and vitamin D. National Osteoporosis Foundation recommend 800 to 1000 international units of vitamin D per day for adults aged 50 and older. In vitamin D deficient individuals, high dose of 60,000 weekly followed by maintenance therapy of 60,000 a month. Some general recommendations: regular weight bearing and muscle strengthening exercises help prevent osteoporosis. Fall prevention should be done. We should try to keep healthy housing so that fall can be avoided. Cessation of tobacco use and avoidance of excessive alcohol intake. These are some population-based strategies for prevention and treatment of osteoporosis. By doing exercise, the prevention is of high grade, and that is given A. Its effect on the outcome of spine fracture is B, and hip fracture is B. Likewise, calcium, dietary calcium, smoking, reduced alcohol consumption, these are all help prevent osteoporosis. Some pharmacological therapy to prevent osteoporosis. Postmenopausal women and men aged 50 and older presenting with following to be considered for pharmacological therapy. Vertebral fracture or hip fracture, if it occurs, we need some pharmacological therapy. For osteoporosis, the therapy includes some anti-resorptive medications and some anabolic medications. The anti-resorptive medications you all know are biphosphonates, calcitonin, estrogen agonist, antagonist, raloxifene, and tissue-selective estrogen complex. Anabolic medication is parathyroid hormone. We know it as teriparatide. Some guidelines from American Association of Clinical Endocrinologists for choosing drugs to treat osteoporosis. First line agents are alendronate, risedronate, and zoledronic acid. While alendronate and risedronates are oral medications, zoledronic acid is given intravenously. Second line agent is ibandronate. It comes in tablet form and taken orally. Second or third line agent is raloxifene, and last line agent is calcitonin. Patients with very high fracture risk or in whom biphosphonate therapy has failed, teriparatide is the answer. Some newer agents are also coming, and these are denosumab, fully human monoclonal antibody against RA and KL, inhibits osteoclast mediated bone resorption, reduced incidence of fractures after 3 years of use, and gain in BMD after 10 years of therapy is significant. Some evidence-based clinical efficacy of medications given in this chart. We can skip it. Individualizing osteoporosis therapy. We can skip this slide. Other newer agents like strontium reniliate. It promotes bone formation as well as inhibits bone resorption. Evidence shows after 3 years of use, significant reduction in vertebral fractures. And after 5 years of use, still more reduction in hip fractures. Other pharmacological therapy, clinical pearls, tips, implications, insight for pharmacological agents, combination and sequential therapy, and appropriate patient profile. Some drugs on the horizon to prevent osteoporosis are anti-sclerostin antibodies, parathyroid hormone related protein, and abaloparatide. cathepsin K inhibitors. These are not available, but these are in pipeline and will come soon. Cathepsin K inhibitors. To conclude, osteoporosis is a condition associated with significant morbidity and mortality. The last decade has witnessed veritable revolution in osteoporosis diagnosis and therapeutics. Much success achieved has been due to enhanced understanding of basic bone biology. Bone density remains most valid and reliable measure of fracture risk. FRAX, other new imaging approaches help bone health evaluation and identify fractures earlier. Currently, number of medications are available for management of osteoporosis. Each drug possesses specific advantages and side effects, like bisphosphonates have been mainstay of osteoporosis therapy, but questions exist about very long-term safety. Bisphosphonates need to be taken on an empty stomach, staying upright and delaying food for 1 hour. Teriparatide be given as a daily subcutaneous injection and used for a defined period of time. Raloxifene increases menopause, improve biomechanics and reduce fracture risk more than do existing products, while giving long-lasting benefits even if treatment is stopped. New and potentially highly effective agents may offer novel therapeutic tools to counteract osteoporosis epidemic. Thank you very much for being patient.